Good afternoon. In this session, we'll try to go over these three objectives. First, I would like you to know the healthcare challenges faced by the refugee women. Second, we would like to address strategies to achieve health equity in the inclusion of refugee communities into research. And then, what can we do to apply the principles of community-based participatory research to avoid a deficit model? The Refugee Women's Health Clinic started in 2008, and our mission is to provide culturally and linguistically appropriate health services to refugee and immigrant women in Phoenix. We seek to reduce, if possible, to eliminate health disparities and cultural barriers to care. Our values: we are locally accessible and we are globally minded, given the issues refugee women have faced back home and while they are here in the country of the host country. For those who have no idea what refugee arrivals are in the States, the state have been a host to over 70,000 refugees for the past 10 years, and majorities coming from Burma, Somalia, Iraq, and other sub-Saharan countries of Africa. At the Refugee Women's Health Clinic, we have the 4 countries being represented. They are reflected there in those data. And we also see, in addition to Iraq, Somali, and Burmese, we do have Democratic Republic of Congo. And because of the issue of sexual gender-based violence, the influx of Congolese means a lot to us, because we have to make sure that those issues of women human rights abuse are addressed. Integration challenges to consider: war and human rights, past persecution and traumatization. These women have suffered all kinds of war trauma and psychological stigma attached to who they are. Racism and stereotyping by host community, language and culture are not shared. Psychological and practical adjustment, of course, their experiences of what they are used to live, their lifestyle culture versus of what the host present to them and what we are demanding them to be. Lack of cultural competent healthcare providers. We all know many of the providers don't want to deal with the issues of facing a refugee and spending 30 an hour doing the first visit assessment consult, whereas they have only 15 minutes to do the work. So we get to take those into consideration. Many instruments are not adapted, to fit the refugees' experience and needs. We tend to use Western methods, and we get to revise and shift, and knowing that we are dealing with a new population. We need to know our population. Women are more vulnerable due to precarious security or physical protection threats as a result of their own gender. When we're talking about disparity in research, we are to think of the groups we are dealing with. And in research, as you know, we have subgroups that are considered more vulnerable than others, and they are there. Pregnant women are among them. And then other factors to consider might be the ability to truly make informed decisions, the ability to make voluntary, choice. Many factors play. Poverty, limited education, experiences of discrimination, political marginalization, forced displacement. Looking at all these issues, refugee women are more vulnerable. They are a distinct subgroup that makes them to be a special, unique group that we should learn about. Involuntary displacement from their homes, experience of persecution, war, trauma, forced exile, pre-migratory and post-migratory challenges, loss of family, everything, and then the struggle to start new lives, and the struggle to shape a new identity in a host country. So We also know that in terms of research, they are lower represented. They are less represented. Not many researchers have done much in terms of refugee health. So let's see what we can do and how we can change it. And then cultural health, socioeconomic standards from Western healthcare philosophies, how we deal with things versus what their myths and beliefs are, what they bring with, can be a challenge. So, community-based participatory research is a model that we all are called to apply. When we are doing research, let's do it with them, by them, within their communities. Don't place it into them. No, let it be with them, by them, and let them participate fully. Our other value, overcoming barriers. We try to provide culturally sensitive care to a growing refugee and immigrant communities. And how we do it? We have fostered a community partnership that is sustainable. It's very strong. We have built, since we started, a refugee women's health community advisory coalition. People such as RJ, they are present. People such as Department of Public Health Services, they are present. Maricopa County Public Health, they are present because at the social services, they are present. Research partners such as academic partners, ASU is part of it. Refugee agencies, they are part of it. Volunteers, complex managers, apartment, they are part of it. Everywhere, everyone who is working directly and indirectly with refugees are part of that consortium to inform the needs and health needs, the priorities of refugee women. We meet quarterly. They share, we talk about our initiatives. They inform of the needs according to what is reported by their constituents, and then we shape new programs accordingly. And then also, it was very important that we consider geographical, variations, and then also locations. And that was a key to our successful implementation of the program. Yes, you can see Refugee Women's Health Clinic is the star there in purple, and then we have expanded to another location in the west, so we can accommodate the needs of the people who are in the West Valley. So we are very locally accessible. This map considers housing, takes into account housing, it takes into account place of worship, ethnic stores, grocery stores, where they are and where they go for their other needs. Community values, they are concerns in CBPR. We need to make sure we consider their values. Respect, resilience they bring with, obedience, the survival, what they have gone through. If they were able to survive the horrific event, there is nothing here that they cannot, be able to adapt to. Respect of elders and knowledge of the community are key values as well. Here, I think I just touched about this. Let the community play a role of ownership. Get to understand their stories, listen to their stories, and see what you can shape. This is our model, our integrated care model. It's a multi-dimensional model that addresses our spectrum of care. So through the Refugee Women's Health Community Advisory Coalition, we identify, first of all, cultural health navigators who play the cultural health brokerage. They are identified by the community members in their own groups, and then they work with clinicians, they work with researchers to shape instrument that they use for research, that instrument that they use for assessing, patient need, and then instrument that we use for interventions or health literacy or other research project. Then cultural health navigators, they do provide care coordination. They come from the different refugee groups. And then trainings also are provided on site to medical staff and allied professionals to make sure that we bring awareness, and then they can increase knowledge on how to care for refugees. These are practical services we do because we are an obstetric gynecological care clinic, so you can read that. This is our team. You can see our team of cultural health navigators. They are amazing. They make sure that they address structural barriers to care, such as transportation, language, health insurance. We work closely with health plans. We do case staffing to address the needs of the patient. We make sure that their insurance doesn't elapse, so we can have continuum of care. So it's very important. And we do also projects that involve partners into care of their women. What do we take from here? CBPR approach tells us that at every phase of research, we need to have a community partner present. We have to design the project with them. We have to implement the project with them. We have to collect data with them, analyze with them. We have to have them co-present with them, if possible, and include them in the publication effort. It's very important that we empower women. Joint and shared leadership in terms of every single process of CBPR is very, very important. We need to take into consideration those values that are listed. We have a case example. I like to do this. Aku Anyi Swastha, Help for Health. Help for Health. This is a community-based initiative that brought Burmese and Bhutanese health advisors together. They were trained so we can provide health literacy into their communities. You can see the team. This was phase 1 team, and then we have on the other side phase 2. The community leaders and community members have identified those who were to be cultural health advisors. They were trained to train others so they could increase health literacy in their communities. 5 of them at the beginning were trained, and they became certified application counselors, and they were able to enroll members into the affordable care plan. Phase 2, the 5 existing recruited 6 new members. All the 11 became certified health advisors. They received trainings on chronic disease management, and they also received training on Affordable Care Act, so they could also re-enroll and enroll new members into healthcare plans. The results were overwhelming. 307 Burmese and Bhutanese were successfully enrolled into healthcare plan. There were dissemination of information everywhere using translated materials. And then also what is beautiful is the fact that they gain transferable skills, and they are licensed for 4 years, and they can work with any other agencies they feel like working with. Of course, there is a need to constantly evaluate what we do, because what happened at that moment, while they were receiving the chronic disease self-management training, we found out that after all that training was from the Stanford University, and it was not adapted to refugees, and it was not tested, so they were having a hard time to kind of navigating the whole curriculum. But they were able, because it was a CBPR approach, they voiced out loud the issues, and the trainers reconsidered, they considered that and then adjusted the curriculum to just study to addressing things by topic, diabetes, hypertension. Then those were the topic they wanted to learn. So I'm showing you other initiatives. They are global, they are national. Congolese ambassador trying to create health videos to send messages on gender-based violence, and then also culturally informed women's health, reproductive, in terms of sexual and gender-based among Somali due to female genital cutting. I will end here because I like to show you some social outcomes as well. People who are partners in the communities are coming together to make sure that we welcome refugees who are new in their first year. So they gather, and then we distribute gifts at every end of the year. This time it's going to be December 18. Last year we were able to cater to over 450 women. So we welcome you to join us, and so we can make a difference. Those are our partners, and we are grateful for them.